Good afternoon. And welcome back, Phil. So we continue from smoothly from the presentation we just had concerning Africa. Now we take a broader look to Canada and Europe as well. And the topic is concerning one of the main themes of ECHAlliance, digital health and data. And of course, it's all about empowering the transition from the traditional situation with healthcare provision to a better one with better quality, better cost, and better accessibility. So let's start by short introductions. I'll let you guys tell something about your background, where you work, and Phil, please start.
Thank you so much, Kari. My name is Philbert Nsengimana. Thank you for the water. I need that. I work as the Chief Digital Advisor at the Africa Centers for Disease Control and Prevention. Previously, I served in the government of Rwanda as Minister for Information Technology and Youth. And prior to that, I started my career in digital health in the private sector. Thank you.
I think I have one. There you go. Yeah. Hi, my name is Michael Bidu. I'm the founder and CEO of MYND Therapeutics. We are a digital health company based in Vancouver, Canada. We focus on digital therapeutics or software as therapy. And particularly, we are focusing on preventing, treating, and managing chronic diseases and mental health. Previously to our company, I also ran 2 digital health technology accelerators. One was a Canadian one. The second one was global. We started with about 50 members. We got to about 5,000 members within 2 years. And I've been in digital health space since 2009. And before that, I was in the mobile and wireless space and digital media. So there you go. I'm looking forward to a very interesting conversation.
Hello, everyone. I'm Tobias Silberzahn. I'm originally a biochemist and immunologist. I'm working in the healthcare innovation space. And yeah, we've had a partnership with the European Connected Health Alliance for many years where we bring the networks together. I host the Health Tech Network, which is a community of now almost 2,000 health tech CEOs and founders, 400 investors, and 400 public sector and private sector organizations. And there we try to connect the dots, as Brian would say. And I'm happy to talk about a few case examples from Europe and low and middle income countries today.
So, Jovan Pavićević, I'm coming from Better. We are a digital health platform provider. In a nutshell, what we try to do is, well, data and digital, this is our bread and butter, to liberate the data from the existing systems in order to make a coordinated care, to eventually simplify the works of those that are providing the care, and it's the health professionals. My role is the International Markets Director and Marketing Director at Better.
Thank you very much. And my name is Kari Kohtamäki. I come from VTT, which is a Finland-based applied research company. The idea is that with the 2,000 researchers at VTT, we create innovations which are then brought to market through companies. And during this session, we also have a few mentee questions. So could we please have the code on the screen just for you to take it so that you can participate? Is it available? Many of you already have it, but okay. Okay, here we go. So if you just click that and I hope you can participate and give your view. And the idea is that we will discuss these coming topics, but you will kind of participate that online so that you can give your views at the same time, and then we can kind of compare the results. So the we don't need that yet, so maybe you can put that away for now. So the first question is if we have today heard a lot about deep thoughts about digital health and data, and you can see that it is intertwined in almost all the topics that we heard from starting from women's health to aging and so on. So now I would like to have some your views on the opportunities it provides, and maybe some concrete examples from your experience from the area where you work and from the region you are at. So, but maybe we start with Jovan, so you can give your view from Slovenia.
Yeah, well, we're present in 25 markets, so we can probably pick any region in the world. We work also in Africa, we work in US, but mainly we work here in Europe. So the company is from Slovenia. We are a 2 million people country, and we've been solving this challenge for, let's say, 10 to 15 years now, and we are quite well digitized when it comes to this, because our data is already in Slovenia in, I use the word liberated. We can use also word open, so it's in an open format. So all of the 2 million citizens' data, it's standardized, it's vendor neutral, so open and ready to use by all of those that need to use it, so institutions, regions, or the whole country and the hospital. So we are now trying to move to the next level, let's say, of organizing this data and improving this, but I want to give actually another case in a more saturated and a more legacy-oriented place, which you all know. It's the City of London, for instance, where in London, in UK, you have this ICS concept. It's like a, let's say, logical region, integrated care systems. And in London, obviously, it's a 11 people city. There's 5 of them interconnecting. So imagine if you would want to do a project where you want to connect all of the participants. In here, it's a lot, the people that you need to speak with. So what they have figured out is something what Jordi Piera was explaining before, and what they're trying to do here in Cataluna. It's the platform approach, where how they see it is, instead of, let me talk a bit maybe first about the journey of the patient. For us as a patient, we are never interacting with a single institution. So we go to our general practitioners, family doctors, then we go to a hospital and maybe to another specialist, third specialist. So it's a couple of, let's say, steps in the process. And normally, from the perspective of the care providers, it's usually just them. It's one system. And this is why I also explained to my mom what we do. You always have to explain to each and every doctor, you know, all over again, your whole medical history and the problems in order to get a full picture. So what they're trying to do now in London is to have a central governing body. They call it One London. In case of Slovenia, it's our Ministry of Health, for instance. Here in Cataluna, it's Catsalut, that is now managing the process for all of this. But if you want to have this process, let's say, singular, you have to have a strong singular governance also over the data. So what they did is they centralized the data on a level of London, and when they are now adding the new use cases or building the existing ones, they're building it centrally, and then they're embedding it into the hospitals, instead of going from one hospital to another and saying, build me this use case, build me this use case, build me this use case, and connecting them. So this is a really good case, and in Slovenia we're doing this for 10 years now, where you have a central governance, and I'm not talking here about the technology. Technology can be decentralized, it can be cloud, it can be anything, but the governance needs to be central on the data, and the data needs to be owned by the institutions, by the patients, and not by the systems. And this is why I use the word liberate, because the current situation is that your data, my data, all of our data is practically a hostage of the system and the application where it is. And this is why we have this problem where we try to do the coordinated care, because the data doesn't flow. And data is the gold in healthcare. It's the bread and butter if you want to provide the proper treatments.
Thank you. And Tobias, I think your case may also deal with the flow of data, I guess.
Yeah, I think I'll talk briefly about a case example from my home country of Germany. As many of you know, Germany has about 1,900 hospitals in total, and you know, I would say our acute care works sort of moderately well, and the problem has been to digitize those 1,900 hospitals, and many of those hospitals are financed by state governments, and of course, if you then have more than 1,000 hospitals that run on sort of very like 1990s like software solutions, right? A normal university hospital in Germany would have between 300 and 500 software solutions, right? Including then a sort of core hospital information system. Then the question becomes, how do you modernize that, and how do you also move from on-premise solutions to then gradually into cloud solutions? And the case example I want to talk about is in the south of Germany, one of the states, Baden-Württemberg, with 11 million people and 200 hospitals. There is now a program started where the aim is to create a multi-hospital cloud infrastructure to connect 4 university hospitals in the southwest with 200 regional hospitals. And, you know, and you can think of it as a sort of a base technology layer that then provides identity management and some cybersecurity type services. And then, similar to how you framed it, Jovan, as a set of cloud-derived use cases on top of that, which might be very mundane things like online purchasing and procurement use cases, where then 200 hospitals can do procurement with each other, or it can also be digital health use cases like Alain just mentioned, teleconsultation, but also then moving into the genomic space and the AI space. For example, then in the medium term, thinking about, you know, AI-driven detection of sepsis cases in hospitals and the like, right? And as you can imagine, if there is now such a multi-cloud infrastructure being built to connect 200 hospitals with each other, that also makes it easier to then do this whole modernization of the IT stack in a more harmonized way going forward.
Thank you. Michael, you might tell us something about the Canadian or North American environment for digital health, and then give your concrete example, and we can discuss.
Sure. So first of all, before I talk about North America or United States and Canada, I'd like to go back a little bit to what I think it's at the core of any conversation that will elevate healthcare transformation, which is us, the people. It's the patient or the consumer, and then eventually the providers and the payers. So let's start with the person that we're all serving. So I think that is a very important thing that we need to understand. It's data and digital and technology, those are tools, yeah, or fuel in case of data. But it's really extremely important for us to understand how to use that, how to collect data, how to analyze it, how to visualize it, and eventually how to turn all that data into value for the benefit of the patient or the benefit of the consumer. So I think that's where I'd like to start the conversation, or at least my point of view. At the core of digital health in general, you know, we have 2 pillars. One is the democratization of healthcare, which means we want to give the power to the people to do self-care, to take care of their own health, using all sorts of digital technologies. So the democratization of healthcare. Number 2, we're looking at the digitization of medicine. And when we talk about digitization of medicine, we're looking at products, services, tools, so that we can help the providers to offer a much better, you know, healthcare, as in preventative, precise, and eventually personalized healthcare. The issue becomes, when we talk about elevating healthcare transformation, is the fact that today, out of 8 billion people on the planet, about 4 billion don't have access to modern healthcare. So it's a matter of access, yeah? We can talk about data and all that, but the primary issue that we have strategically is how do we make sure that everyone on the planet has access to healthcare. So I think that those are some of the things that are extremely important. Now let's talk a little bit about the United States and Canada. United States has the largest healthcare system in the world. It's the most expensive system in the world, about almost 19 to 20% of their GDP. It's close to $4 trillion. $4 trillion. The whole industry, healthcare industry worldwide, it's about 8.5 to 9 trillion. So you can imagine how important that system is if you want to do innovation and you want to serve the needs of that massive system. Canada, interestingly enough, is kind of the second most expensive system in the world. We spend about $240 billion in healthcare, and that's all public healthcare, and probably another 60 billion in private. So it's kind of an 80–90% public and about 10% on the private side. We have had a couple of initiatives around data and digital in Canada in the last decade or so. We try to make sure that everyone has an electronic health record. We spend billions and billions of dollars to make that happen. Yet, still in Canada, we have 13 different healthcare systems. Each province has one healthcare system, and then on top of that, we have a federal system. And strangely enough, they don't talk to each other. So it's a problem that it's not just in Canada, but in many other parts of the world. However, there's a lot of good things that are happening in Canada in terms of innovation, in terms of startups. But I think, again, to the purposes of this conversation about data and digital and elevating the healthcare transformation, I think we see now, after we went through internet and mobile and digital, now with the help of AI, we're now going to a very different kind of game. It's almost like we see a new revolution in how do we use data. And so data means that, when we talk about digital transformation, we're looking at products, we're looking at services, and we're looking at experiences. We're looking at how we use, technologies like virtual reality and augmented reality, for example, to treat chronic diseases and mental health. Something that has never been done before in the healthcare system, whether it's Canada, United States, or other parts of the world. So I can go on and on and on with examples. I can tell you that in the province that I'm coming from, in British Columbia, you visited Victoria just last week. Yeah, we spend about $22 billion in healthcare. We have a population of about 5 million people there. And generally speaking, the healthcare system, it's good. But we have issues around wait lists, for chronic pain, as an example, or mental health issues. So we're looking at how do we, improve data and digital experiences. We also have a significant database of genomics in British Columbia, but the data is sitting there. So the question is like, what do we do with that data? How do we turn it into value for the benefit of the patient? And so that's not really happening to the extent that everybody's happy about it. And I'm curious to hear about your experiences in Africa and other parts of the world, and I'll stop right there.
Well, there are so many areas where there is a lot of applications for data in healthcare. I'll touch on 3 topics. Number one is data for decision making. When I look at several African countries, ministries of health, national public institutes, they all have some kind of system that allows them to collect reportable data from health facilities, that allows them to understand better what kind of decisions need to be made, how to allocate the few resources that are available, both for tactical and strategic planning purposes. If you visit any Ministry of Health today, there will be any number of dashboards that have been developed, some before COVID, some during COVID, and even after. So I can feel that there is a genuine effort on the part of policymakers in Africa to start consuming and using data for decision making. The second area is in the area of supply chain and logistics. Just trying to get the medical products in the hands of people on time and in good quality, whether they need cold chain or not. And in my own country, Rwanda, one of the things we discussed in the previous session was the use of drones to deliver urgent medication, starting with blood. Mm-hmm. And that is saving lives as we speak now. As I speak, I'm sure a drone is taking off with a packet of blood or any other urgent medical supplies, because we have now close to 400 flights every day going to different health centers. And we are talking now about delivering to the doorsteps, home deliveries of medical products using drones in Rwanda. So that is happening, and I think a lot of data is being generated, is being used, and is going to keep helping the government improving public health delivery. The third and the last one, I'd like to invite us to those who have their mobiles to Google something interesting. It's called the pandemics that didn't happen. We are so much fixated on what happened. There is a lot of work that gets done that is stopping pandemics from happening. As a result, no one talks about them. So if you go to that page, you will find that there was a second Ebola pandemic that was stopped in West Africa. Nobody knows about it. Just across the border to my country in DRC, once in a while, there are Ebola cases, but they never result into the kind of pandemic that shut down the whole world, because pandemics provided an opportunity to strengthen health systems for preventing, detecting, and responding to disease threats. And as a result, those pandemics have been stopped. The list continues. Nipah pandemic in India, cholera pandemic in Burkina Faso, Tanzania. So the area of disease surveillance is an area where a lot is being done as we speak, and pandemics are being stopped before they happen. Thank you.
Thank you very much. I could continue with a Finnish example on how to utilize the data. In Finland, we've had a program called FinGen during the past few years, whereby the genome of 500,000 people has been measured. And the idea is then that this genomic data can be combined to medical records and national health records, so to find, let's say, the connection between certain genomic structures and certain diseases. And this has already produced results, so that we now have learned to better understand the roots of certain cancers, for example. So just an example of combining the data which we continuously gather from patients, the records that we get from consumption of medications, and finally the biobank data. But okay, now it's probably the time for the first mentee question. You already had a glimpse of those, and we start talking about, let's say, how can we make this change happen? Whose buy-in is actually needed? Is it the politicians? Is it is the question of funding? Is it the question of technology? So that's the next topic to discuss. And if I can have the mentee slide, then you can also give your voice during the discussion. But who wants to start with this buy-in question? Yeah, Jovan.
I can start, because we are obviously a vendor, so we interact with everyone. And I think that eventually it's everyone's buy-in. You have a case, I mean, healthcare, we know that it's, in Europe at least, but probably globally, it's underfunded industry. So there was a question of money. Then we have now this RRF funds, next-gen funds. So there is no money in Europe, at least on the paper. But then there is a lack of, let's say, people that need to write the project, because also people don't know what they want to do many times, sadly. And they're usually the care providers are, both on the regional, country, or hospital level, they're understaffed to build these projects. But even in the cases when they build these projects, then it's about the political decisions. Who signs off this project now, and it's good, and then it's not going to be in the media. So it's kind of a zoo where you need to orchestrate everyone. And then eventually we come, and I think it's the least, the doctors. I think we are now breaking this barrier, because maybe in the past, and I'm in the industry for 10 years now, we had this pushback from the doctors of the digital. I think this is not the case anymore. I think they're starting to embrace the technology, but the time that we need that the technology comes to them is just too long, and it needs a buy-in from everyone but them. Because when we are implementing projects, when we speak with the doctors, we have no issues there. It's the project management, project governance, political decisions, and this is the, I would say, bureaucracy that's somehow, or administrative process that's on our backs, and also on the backs of the clinicians before implementing the technology. So, from my perspective, the healthcare staff would be the last one, and I think the governments eventually the first one. Like also it's here, I see now, they are the ones who need to get this buy-in. And we have a good case here from Catalonia and Catsalut. Jordi was discussing this previously, where there is this strong political movement and decision to make this change a reality, and obviously a funding. He presented also the numbers to make this happen.
Thank you so much. Next one.
Well, I would like to make the distinction between one part is setting things up in a way that they work, and then the other part is creating services that are useful to healthcare staff, as you just said, or patients, right? So if I take electronic patient records as your example, right? We have some countries in the world that have set it up and put a good set of services in there where more than half of the population and most healthcare staff are using them. And then we've got other countries, like my home country, who set it up in a way that there are not so many useful services in, and we've got less than 1% of the population who downloaded it. And pretty much most of the ones that were downloaded are empty and not used, because people generally don't like or don't need an app that is a PDF storage repository of stuff, right? So I think it's not like that an electronic patient record is either good or bad, or useful or not useful, right? It's often a way how they set it up and they design it. I think the point with governments now being on top, right? Coming back to the case example that I shared earlier, but 5 ministries are involved in that large-scale program in the southwest of Germany. The Ministry of Health is responsible for 200 regional hospitals. The Ministry of Science is responsible for university hospitals. The Ministry of the Interior and Digitization is responsible for the overall digitization strategy for the state, as well as topics like cybersecurity. The Ministry of Economy is responsible for then innovation portals and more clinical trials in the country and getting additional investments into the country, right? And then there is the overarching ministry also involved, right? So in that sense, it's usually not like, you know, that it's just sort of one department, right? In many cases, we have then a multi-ministry setup, especially in health, where we often then go into digital identities and topics like that, or mobile wallets and payment systems, right, that then actually move also beyond healthcare. So therefore, I'm very grateful to then Alain Labrique and Garrett and his colleagues to actually set up this global initiative for digital health, because we've got so many countries, right, and you are working on similar things, Phil, in Africa. We've got so many countries that are going through similar things, starting with electronic patient records, e-prescription infrastructures, remote monitoring platforms, and the like, right? So that there is actually a need to then think about what should be reference architectures, what should be financing models, right? What should be governance models, to your point, so that we are not sort of all reinventing the wheel all the time.
If I may comment, you mentioned the collaboration of different ministries, which is wonderful and which is necessary. So in Finland, what happened was earlier on, the Ministry of Social Affairs and Health and Ministry of Economy were on different tracks when we were talking about, let's say, utilization of technology and participation of businesses in developing digital health infrastructures and solutions. Then the initial comment from the Ministry of Health was that this is about people's health, not about business. Now, of course, that has changed, and they are aligned, as you said, and everybody realizes that we need all these parties to develop better solutions.
All right, so I think this is a good question, but it depends on what system are you looking to sell into. I can tell you that in the last 10, 12 years in the United States, not so much in Canada because it's a public system, but in the United States, what they realize is that the direct-to-consumer market played a huge role in the adoption of digital health technology. But the United States is a kind of very unique market because they respond extremely well to consumerization. Everybody's a consumer, and everything, all the technologies, everything that whole country does is targeted at the consumer level. So in that case, this kind of stats that I see here, or responses, would look very different if it was just the United States. In Canada, I'd say that this is probably typical. Obviously, the government has the money and the responsibility to deliver public health. It's a contract with your citizens, and therefore, indeed, you need the buy-in from the government. The problem with the government is that the government doesn't know much about innovation. They're stuck in the past, in my opinion, but things have started to evolve for the better. In the last 10, 12 years, we've seen an improvement. We've seen better adoption of digital health, and in a way, the COVID, shifted the whole perception and the understanding of what digital technologies can do. Virtual health medicine, for example, huge change in their minds, in the government's view of digital technologies. And then I would say that the healthcare staff, I had physicians in British Columbia in Canada who never believed in digital health technologies whatsoever. And then COVID hit, and it's like, now we're believers. Like now we can actually treat patients using virtual healthcare for psychiatric reasons or for other types of reasons. So I would say that the governments and healthcare staff, the healthcare staff doesn't really have money, but they want to say that, we like this technology. It works for us. It fits on within our workflow. So for that reason, they're influencing. They don't have any buying decision by itself. They don't have the money. Same thing with the hospitals. The hospitals in public healthcare systems, their margins are extremely small. So they don't really have the money, but they can say, we'd like this technology. Yeah, exactly. So the healthcare staff, and then the hospitals, and then the insurance, I would say that the insurance should have a better role or a significantly larger role in the buy-in, because they can actually affect all the healthcare and the wellness part of it. I mean, this whole summit is called the Digital Health and Wellness. We forget the wellness part. We think only about healthcare. But healthcare is just about, medicine, healthcare, hospitals. It's an episodic thing, whereas wellness is what you do your whole life. So with insurance, we can actually work with the insurance to figure out some business models where indeed they can buy in, but they can buy in benefits for the population. So there you go, that's my take.
Yeah, and I think that insurance might be interested in prevention part of it, especially in Europe for occupational health. They would probably be keen to adopt the digital technologies to save money from themselves.
Well, I mean, you see, this is one of the things that, to me, I have been, again, in digital health for 13 years. And for me and for a lot of other entrepreneurs, the value proposition to our customers, whether it's a hospital or a healthcare authority or a ministry of health or a government of some kind, it's very simple and clear, meaning digital, it's a much faster technology to adopt. Like you can deploy a digital technology within days or weeks or months. That's it. It's much cheaper, significantly cheaper. Look at artificial intelligence now, looking at radiology, for example. You pay hundreds of thousands of dollars for a radiologist to look at all these pictures. You have artificial intelligence who look at the same radiology picture, and the AI does it in less than 2 seconds, and it costs less than $1, as opposed to, I don't know, $6,000 or $800. So we have this kind of solutions that do work. I mean, the value is there. It's faster to adopt, it's faster to deploy, it's cost effective and all these things. And talking about mobile phones and smartphones, we can deploy it right there. There's 7 billion smartphones in the world.
Exactly.
Yeah?
Which
So we should be able to increase that adoption.
we also get to the African example. I mean, I would like to add one element to this question, which is the digital literacy that has been discussed earlier on here. And my understanding is that Africa has, we just heard that the African population is very young and they are heavy mobile users. So what do you think about?
In fact, I don't know whether people can change their minds and vote again, or we have only one shot. Because this is how I had voted also initially. I thought governments would be right there on top, and then the staff, and then the users, and so on. But then I realized that things are really changing very rapidly. In Africa, primary care is 80 or 90% in some cases in the hands of governments. It's public.
Yes.
And so whatever decision that the government makes, really, if it's a use of a platform, it gets everywhere at once. So governments have a huge say. But if you go one step further and wonder on which basis the government is making those kind of decisions, what is the demand side? And that's where the users come in. Many governments have embraced experimentation. So they let a number of solutions sort of be tried before they decide which one they go for. And usually they tend to go for something that they see a lot of demand and adoption from the market. So to that extent, I'm wondering, is it the users who are determining the decision, or is it the government? So I think we need to sort of even simplify a little bit this model and say this is the supply side and this is the demand side, and ask the question, is it the demand that is pushing adoption? Is it demand-driven adoption, or is it a supply-driven adoption? In that case, governments, hospitals, because they are owned by the government, in many countries, including my country, Rwanda, insurance is also owned by government. 90% of citizens are part of a public insurance scheme. So all these three bars would belong to the supply. And then you also build a demand and re-ask the question, is it demand-led or supply-led? And I would say that it used to be and still is supply-driven, but in a couple of years from now, I think there is a critical mass of people with the right enough digital literacy that will shape the demand side, and the demand will lead the adoption.
This is very, very interesting. Can we have the next Menti slide as well? Because we would then continue from let's say, the buy into the challenge issue. The question then is, where do you see challenges? What is the hindrance, barrier for adoption of digital health? And this will be a word cloud where you can just write any word, and of course you can use the words that already are on the screen, but we'll see how it gradually evolves. But let's see who wants to start from the panelists on what are how do you see the barriers? Why we all know that we have heard so many times that this is important, this is necessary, but just doesn't happen.
Happy to start with the financing side. So if we, maybe I'll start with Europe, right? We usually have a moderately well-functioning acute care system, right? And the hospitals are often paid via DRG systems and similar systems in the ambulatory space, which, you know, works reasonably well when one of us gets run over by a bus here, and then they will stitch us together, and they get money for that. I think this is not the case in most countries for digitally enabled preventative care, right? Some of it is happening in the occupational health setting, and some of it is happening out of pocket, and a little bit is happening via health insurances. But we don't really, as societies, keep our population systematically healthy, related to sleep, nutrition, fitness, and stress management. And then the other part with chronic disease management, it's exactly the same, right? Where you know, we then often, if we now talk about digital health, we often get funding categories, maybe patient remote monitoring funding categories via CPT codes in the US, or a digital therapeutic funding category via DiGA in Germany, or a teleconsultation funding category. But my thought is that this will make it very hard to actually achieve real good patient outcomes, improve health literacy, and I would be more in favor of some sort of capitation-based models or value-based models, where then, but if you have a great chronic disease management solution and you manage 20,000 patients, then you get the required amount of money and you are monitored to deliver good patient outcomes. But if you now do this via digital therapeutics or patient remote monitoring or teleconsultation or symptom checkers or chatbots or God knows what, right? That's your problem, right? So in that sense, I would be an advocate of shifting from this sort of funding each digital health category one by another, right, to actually more integrated funding models.
Well, Tobias, I'm glad you mentioned that, because I think there's a shift from fee-based healthcare to value-based healthcare. And I think in a way that's what you are suggesting by focusing on performance and health outcomes. I think in my view, the barrier to adoption, I would like to think more about the culture. I think it's very important for us, all of us, to understand that health is all you've got. And you should pay attention to your health every day, regardless what the healthcare industry does. And I would start with food, for example. Yeah, food as medicine, in a way, which is a great trend that is starting to happen again. So think about that. I'm going to talk a little bit on obesity, if that's okay. So obesity, for example, it's a chronic disease. Globally, it's an epidemic. We have about 2.1 billion people with overweight and obese, of which about 750 million have obesity. What does that mean? Well, it means that obesity costs all of us about $1.7 trillion annually. So what's the problem about, you know, what's the barrier to adoption? How can we help all these people? Because in the last 50 or so years, no country in the world solved obesity. So the solution, when I started looking at it and understanding what the adoption, that the barriers are, one of the problems is that we don't have enough obesity experts in the world. Like in Canada, we have in Canada we have 100 obesity experts, supposedly trying to treat 8.3 million Canadians. An obesity expert can only see 500 to 800 patients in a year. Multiply that by 100, that's 80,000. So 80,000 of 8.3, that's less than 1%. So what's the barrier there? The barrier is the fact that we cannot scale. Physically, we cannot do it. However, using technology, using software, using AI, you suddenly can do things that were never possible before. Like I spoke to a Canadian obesity summit and I said, hey, imagine this. We have this obesity expert, and instead of seeing 500 or 800 patients in a year, we can see 8,000 or 10,000 in a year by using digital twin technology and AI. And they were like, what are you talking about? And now that brings me to digital literacy. The problem is that even the physicians, the hospitals and all these people, they're so busy doing the work that they're doing every day that they don't know what is going on in technology. So the digital literacy is not just a problem for the patients and the consumer, but it's also a problem for the healthcare providers. And the payers, for that matter, the governments, the insurance, and all the others. So those are some of the barriers. But I would say that we know for a fact that culture always kills strategy. So culture is the most important thing that we can change in people's perception, and that eventually will actually drive the demand. Yeah, and it will focus on prevention, and then precision, and then personalized medicine. To me, those are the kind of things that about barriers to adoption.
Thank you, Michael. Other views for the challenges?
I can maybe challenge a bit the cost and the money, since it's here. So for instance, in the U.S., so we said it's 4 trillion. So it's probably it's the most ineffective healthcare system in the world because you spend 4 trillion on treating 350, or I don't know what's the population. Yeah, so 20% of their GDP goes there. You don't see this anywhere in the world. So they have the money. But in the US, the challenge is the business model. So in the US, the model is they want you in the hospital. You could see literally, there is our CEO also shows this slide. They're competing on the EMR times to get accepted and treated between themselves. In Europe, hospital, ideally, they don't see you. They don't see you. In the US, they are fighting for you, and this means that also the vendors, the technology providers, are fighting and trying to lock the hospitals into their technology. So if we want to have a second opinion, go to other hospital or whatever with our data or as the owner of the data, we can't because we are owned in that sense by the hospital and the system there. So it's not about the money. There is money. It's about the business model. Then we go to Europe, where it's a different business model. So the government owns the insurance. Insurance is a single payer of hospitals. And there was always a question of money. Then we have COVID, a full reset, understanding that we need the digital, and at least on paper, we have the money finally. But now we come to the matter of people. They are understaffed. We have Slovenia, I think, from the RRF, we got 80 million for digitalization in healthcare. This is huge money for us. But we don't have the right people on the side of the care providers, on the side of government, with whom we can speak about making these projects reality. We are now trying to, and I want to touch base on the ministries that you mentioned. We have, for instance, Ministry of Digitalization in Slovenia. I know there is one in Greece. I don't know if there's one in Germany, and this is popping up, but you have to have the right people now in the ministries. But the question is, can you pay these people enough? It's IT industry. We know that the private sector is paying them well. So one of the good maybe initiatives, and I hope it lives, in Slovenia, we are trying to establish from the ministry level a private company, so a limited company, which is owned by the government, but it's acting as a private company, so they can break these ranges of salary of the traditional, because in general, at least in Slovenia, it's like this. You progress with your education and with age. They don't care how much you know. So this is one of the initiatives that I think that's going to break this barrier, at least there, where they're going to be funding this private company and be able to hire good people to be able to deliver the projects. Because currently, the biggest barrier, and I see this across the Europe, it's lacking of people that can deliver this project. The money is there.
Phil, Africa.
Can I give my turn to the audience, the one who wrote too much availability as a barrier to adoption? I'm intrigued by this opinion. Anyone? Yeah.
We can have the mic if there is somebody who wants to comment on that one.
Too much. One member of the audience said a barrier to adoption is too much availability. If you can see on the screen. So I'm intrigued by that opinion. I think the rest is quite clear: cost, knowledge, regulation. But if the person is not perhaps willing to share, okay, that's fine. I would comment on the cost because it has two sides. In the US, it's not an issue of cost. I agree with that. US spends on average like $11,000 per capita or more per year on healthcare. In Africa, on average, we are still below $100 per capita. So you can understand that investment available to even implement and roll out integrated digital health systems is really still very low. When I was looking at the slides previously by our colleague from Catalonia who was presenting the money that they have to digitize health in Catalonia for a population of 7 million people, it's much more than what countries have for the entire healthcare sector in a year. So that would be the budget that is going to cover, let's say, 100 million worth, per capita if you put it at the African scale. So I would say money works both ways. There are areas where much more investment is still needed to really implement robust, interoperable, integrated digital health systems.
Thank you. Any more views on that one or quick ones?
Well, I would say that I attended most of the sessions today, and I think we are not doing as an industry, I'm talking about healthcare in general, what other industries have done, like financial services, for example, or other types of industries. Like, we are not trying to understand how to serve, for example, women's health. It's a massive issue. How do we actually create strategies to really improve the health outcomes in that particular population? We're looking at all sorts of areas, from cancer to sterility to fertility and so on and so forth. Then another area that I looked at was aging. At least in Canada and British Columbia, about 80 to 85% of the budget goes to people over 65 years old. Yeah? So we know that that's where the money is going. And we don't seem to be doing enough for the aging population. Yeah? They're lonely, they don't get the right support, and so I would say that one area to improve the adoption of digital health technologies is by understanding all these different segments. It's called segmentation in other industries. In healthcare, they don't like it to call it segmentation because politically it's not correct. But taking care of children, of youth, of women, of men, of all sorts of other genders or gender orientation, to take care of the aging population, suddenly then you can show results in that particular population. And I think that could be a way for us to improve the adoption of digital health in the various populations and get them to communicate and demand more. So just an idea.
Okay.
I realized that I didn't complete my statement because on the cost, while I highlighted that more investment is needed, I think the key here is to use digital to deliver healthcare more affordably, more efficiently, and be able to meet the challenge of insufficient or gaps in financing healthcare. So how can we use digital as a driver for healthcare quality and affordability? That's the opportunity for innovators.
Jovan.
Yeah, I'd just like to add one thing when I'm reading the question, actually. So one of the barriers of the adoption of this is actually the data itself. So you've said that on average, a hospital in Germany has 500 applications. So imagine that your healthcare data is spread in a single hospital in 300 different applications, and you want to have a single view on your data, and you want to share this data with others, so it's impossible. And it's about the mindset. I'm trying not to be technical when I'm speaking. It's really hard, but it's the mindset of how we are doing this. Because usually we people, when we buy and try to solve something, we try to solve what we see. 15 years ago, when we started as a company, our journey of data needs to be open, we were probably the only lunatics because people were trying to solve issue of one system by changing it with other system. And this didn't solve. There's 300 of systems to change. The issue of this is way below the systems, and it's how the data is actually in a technical sense, and I'm not explaining structured, stored, and governed. And this is the problem, because when you have 300 to 500 systems that needs to talk one to another, trust me, it's a technical mess. And this mindset, it's also something that we are quite trying to promote, about a different approach of how to understand the digital transformation. It's from bottom up, not from top down, and this is actually what was also today a couple of times on the slides.
Thank you very much, and we noticed that we are running out of time. There's one question to all of you. If you would say that, what is the key success factor for making digital health and data really work? You could just pick one. What would it be? Who wants to start?
People. It's all about the people. Technology is there. It's only about the people, nothing else. Very simple on all levels. So top down to the user, implementers, everything is about the people and the patient eventually, because they are the owners of this.
Another P, partnerships.
Partnerships.
I think one thing that I like what has been done in the Netherlands is to think about what should be reference architecture, so that then the whole mess that we currently often have can be cleaned up, right? And also what Alain Labrick and Garrett are trying to do, right? To sort of build a digital first health system, right? Where it's not a wild chaos of 2,000 different things, right, but rather a well thought through. So in that sense, there I've been impressed what I've seen there in the Netherlands.
Reference architecture. Michael.
People.
I think
it is people.
we
Really.
the solution is people get 2 votes versus others. So I guess that's from our side. I think we don't, unfortunately, don't have time, or do we have time for questions? We do. We do have. If there is a question in the audience, we can try to answer or comment.
Any questions? Come on. Adam.
Hi. Sorry, Adam Millward from Metadata Works. Thanks for the really good panel. I think you've talked a little bit about reference architectures and kind of sorting out the kind of various different thousands of different data points. I guess there are a few out there. You've got, well, I won't preempt it. There are a few out there. What would be your advice in terms of going out and selecting them and looking at the benefits and drawbacks of each?
Well, I think it should be country-led in my point of view, right, and what is now being done at the global level to bring ministries of health across countries together to think through sort of what are those target architectures or what are those standards and how are those standards implemented, right? So that, right, in the European Union, we've had in many instances each country doing stuff, right, in the pharma space, in the medtech space, and then we have a few decades of harmonization discussions of how do we harmonize, right? So I think for digital health and data, also what you are doing, Phil, in Africa with colleagues, right, sort of aligning on those things across country first, and then moving forward would be my preferred approach.
I have a question for the audience, if you don't mind. The question is, how many of you would like to see an elevated transformation in healthcare? Please raise your hands. Okay, almost like 90%, almost 100%. How many of you are from the healthcare system, please? About 20%. Okay, and the third question is, never mind. Yeah, it's really about change, transformation, and can you actually start tomorrow based on everything that you've heard? Can you raise your hand? See, not much of action. But yeah, thank you very much.
But some. So thank you very much, audience, for your attention. Thank you, panelists.